Hello, I'm Marc Steben. I am a family physician at HPV Global Action, a nonprofit organization, and a professor at the University of Montreal in Canada. Today I'm joined by Dr. Barbara Moscicki, who is a distinguished research professor of pediatrics at UCLA, the Division of Adolescent and Young Adult Medicine in Los Angeles, USA. And she prefers to be called Barbara. Today we'll be discussing the burden of cancers and other diseases caused by HPV, and how can we help the condition with preventing them with the HPV vaccine. The agenda, going beyond cervical cancer, the other cancers and diseases related to HPV, recommended HPV vaccination schedules and improved indication, and the role of primary care providers in education and overcoming vaccine hesitancy. The burden of HPV is pretty wide. HPV causes a range of diseases, and when we look at the estimated annual incidence of new HPV-related cancers worldwide, we know that women will have 620,000 new cases per year of cancer, male 70,000, and all cancers related, all cancer, 4.5% will be associated with HPV. And the HPV genotypes, or types for short, causing most related diseases, 6 in 11, of course, will be the cause of anogenital warts and a recurrent respiratory papillomatosis. Also, we have the HPV that causes associated with cancer of the cervix, the vulva, the vagina, the penis, the anus, and the oropharynx. We have the 7 high-risk HPV that we find in the 9-valent vaccine, HPV 16 and 18 predominantly, 31, 33, 45, 52, and 58. And the other high-risk HPV that causes far less cancer, but still are high-risk, HPV 35, 39, 51, 59, and 56. Now, Barbara, let's discuss some questions submitted by our audience about the burden of HPV disease. Question number 1 is, the necessary role of HPV in cervical cancer is well understood. What is the role of HPV in other types of cancers?
I'd first like to clarify that HPV is important in cervical cancers, but it's HPV persistence. And we need to know that a lot of women and men are going to get HPV. They're transient and they will be cleared. It's those that persist that go on to invasive cancers, including the cervix. We also know that HPV infection, as you just pointed out, that are associated with other cancers. So anal cancer is one that always comes to mind. About 90% of anal squamous cell cancers are associated with HPV. HPV 16 and 18 also lead the pack. We have about 15 to 48% of vulvar cancers, 50 to 78% of vaginal cancers, 53% of penile cancers, which even though we don't see much in our higher income countries, is actually quite a burden in lower income countries. And then we have oral pharyngeal cancers. So in the US, it has now surpassed the number of cervical cancers, and 71% of oral pharyngeal cancers in the US are associated with HPV. Once again, HPV 16 leading the pack.
That's a huge burden. Is the type and incidence of HPV-related cancers changing?
Yes, in a very short answer. And the long-winded answer is that we know that certain things are going to affect it, like age. Vulvar cancers, anal oral pharyngeal cancers are really those that occur in older age individuals. So we're not seeing quite the impact of the HPV vaccine because of this very long time from exposure to what we see in individuals, mostly those older than 50 years of age. Whereas the cervix is kind of in the middle. We begin to see rates rise in the late 30s and certainly 40s. And in the US, we actually are seeing a decrease in incidence of HPV-related cervical cancer in younger women, because those are the ones that are getting vaccinated. On the other hand, we are seeing astronomical increases in oral pharyngeal cancer, specifically in males. And this is another reason why men need to be, or boys, I'm going to say, should be vaccinated as well as girls. So anal cancer. Anal cancers in the U.S. have increased about 3% per year. And they are more common among women than men. However, subpopulations, such as men who have sex with men, and both men and women living with HIV, are also at very high risk for developing anal cancer. So when we took, again, the oral pharyngeal cancers, anal cancers, and penile cancers, this underscores why boys need to be vaccinated as well as girls. So Marc, let me ask you about Canada. I talked a lot about the U.S., and we have a border between the U.S. and Canada, but I'm sure there are great differences that would be great if you could talk about them.
Yeah, we were shocked when we had the presentation of the rates of cancer in Canada previous to the onset of the COVID epidemic. We saw a mean of 3.7% increase per year for 5 years, and that was before COVID. And knowing that
Wow.
COVID was a huge problem to get women to get their cervical cancer screening, we are facing a huge tsunami of cancer in the future. We think that it's going to increase for a while. We still have problem accessing screening and primary care.
You really point out something so important when we talk about prevention, in that we know HPV vaccination is great, but we cannot stop screening for HPV-associated cancers. Particularly, we do have screening for cervical cancers. In the US, we've now introduced screening even for anal cancers for specific high-risk populations, those living with HIV. And so we need to get the message out that even if you got vaccinated, we cannot stop screening for the cancers that we can actually detect as a precancer and treat them.
And Barbara, this certainly puts the strength of the prevention not only on vaccination, but also on screening. We forget that vaccination will reach its maximum efficacy maybe in 15, 20 years. And their mothers and grandmothers and aunts and cousins still need to be screened. Those women that were sexually active before vaccine was available certainly still need for their life to go for cervical cancer screening.
And unfortunately, we don't have screening for vulvar, vaginal, penile, or oral pharyngeal cancers. So we can only hope that we can eventually identify good biomarkers for screening as we have for cervical and anal disease.
And in the meantime, I think people should be aware of the early signs and symptoms of the other HPV-related cancers.
No, that's a good recommendation. Comes to mind in the U.S. now. Dentists often are doing, exams orally as well as, checking out lymph nodes in the neck. We know that we recommend both men and women who are having rectal bleeding or pain should also get screened or be seen, by someone else. So we have some work to do, but there are some signs and symptoms, as you mentioned, that at least you might be able to detect early cancer.
Aside from cancer, what other diseases are related to HPV infection?
As you pointed out earlier, 6 and 11 is a predominant cause of anogenital warts. We are seeing, once again, great data from places that have actually pretty good vaccination rates, even among girls, where we're seeing the prevalence of anogenital warts plummeting. I'd like to take a little bit talking about recurrent respiratory papillomatosis. We have the juvenile onset, which is, we believe, mostly associated with mother-to-child transmission, and adult onset, which is believed to be sexually transmitted. These are basically warts that occur on the larynx and other parts of the respiratory tract. But what's critical is when we have the juvenile onset, these are little airways. So those warts can actually obstruct their breathing. So the morbidity associated with this can actually be quite high. Great news, we are seeing in the US already significantly reduced rates. by vaccinating women and children, and they're becoming adults and they're having babies, and we are protecting the babies. So once again, this is so critical that this vaccine can not only prevent cervical cancers, but I just outlined how many other diseases and cancers can be affected by high rates of HPV vaccination.
Now let's talk about recommended HPV vaccination schedules and the approved indications. We know that the effectiveness and specificity of HPV vaccine is such as HPV vaccine are among the most effective prophylactic vaccine available. Vaccine offers sterilizing immunity against HPV types in the vaccine for at least 14 years. Estimates suggest HPV vaccination could prevent 90% of HPV-related cancers developing, and anogenital wart diagnosis decreased 67% in girls, 48% in boys age 15-19 after 5 to 8 years of HPV vaccination. So we have 3 vaccines available, HPV types that are targeted by HPV vaccine. So we have the bivalent vaccine targeting 16 and 18. We have the quadrivalent HPV vaccine targeting 6, 11, 16 and 18. And the 9-valent that adds protection against 31, 33, 45, 52, and 58. So vaccine availability varies by country, and only the 9-valent vaccine is available in high-income countries such as Australia, Canada, Europe, and the United States. So now, Barbara, let's discuss some questions submitted by our audience about HPV vaccination schedules for different patient groups. What is the recommended dose schedule for HPV vaccination in young people?
So I'm going to first talk really about the US, and then maybe you can talk about Canada, because there are variations between countries, high income and low income. So in the US, we basically recommend a 2-dose series in those aged 9 to 14 years. It's recommended that be given at 0 and then again 6 to 12 months later, with a minimum interval of 5 months between dose 1 and dose 2. And there's data to show that that 12-month may actually give you higher titers than even the 6-month, which actually fits with a lot of schedule, that annual physical that, you know, a 9 or 11-year-old would come in. So that's quite convenient. The WHO have it start 11 to 12, but again approved down to the age of 9. There are some studies that are pushing that age down to even age 4. So, but those studies really have not been completed quite yet. So maybe you'd like to comment just on what Canada is recommending right now.
Canada has a strategy of giving the vaccine in school, and we already had scheduled routine hepatitis A and B shots given at the age of 9. So it was easy to add a vaccine to the hepatitis vaccine. But I think you made a very good comment about lowering the age. We know that as kids grow in age, less will go to school, and those that drop out from school are usually those that are the most at risk of disease in their future. I think it's important to realize also there are differences that may exist between labeled vaccine indication that are approved by country agencies and the country recommendation that comes usually from professional body of experts. And the age of vaccination may differ between countries for practical reasons. And what is the recommended dosing in older teens and adults?
So I'm going to start with the U.S. What is an older teen and adult? It's called our catch-up group. It's age 15 years to 26. Now we want to give a 3-dose. It's given at 0, 1 to 2, and again at 6 months. And once again, it's going to vary by country. The HPV vaccine is not cheap. It requires a cold chain. So for lots of practical reasons, countries do have, variable indications and recommendations. However, as I mentioned, it is a 3-dose series. for those individuals. But now let's talk about a slightly older group that's actually approved in the US as well. That's the aged 27 to 45 years of age. So most of those women have initiated sexual activity. So data show that it's not as effective, but it still has effectiveness in this age group. Why? Well, you know, there's more than one HPV type in those vaccines, and so the women can continue to get some protection. But in the US, we call it shared decision-making. I'm just curious how you handle it in your family practice.
Yeah, it's about the same, but you mentioned for female, but I think that male also are to be counseled about the potential benefit they may have from HPV vaccination. And of course, we have some situation where it's even more of a discussion topic between new sexual partners, like for women that already had abnormal pap smears or men that had genital warts. So there might be other reason of vaccination. We know that most people will keep their HPV once they're infected, and it's their immune system that controls the virus. So for those people that are in a situation where they're changing sexual partners, especially if there's a past history of HPV disease, I think it's quite important to have this discussion. And what are the considerations for patients who are immunocompromised?
So HPV-associated cancers are a big problem in those immunocompromised individuals. So we certainly consider anybody who is immunocompromised. Those living with HIV certainly come to mind right away. But then we have those undergoing chemotherapy, autoimmune conditions, and those that are on disease-modifying therapies. Such as those even who undergone solid organ transplants. So all of those individuals seem to be at high risk, and so we recommend always giving a 3-dose schedule at 0, 1, 2, and 6 months. There's also a question like solid organ transplants. We know once you put them on immunosuppression, they actually respond less to the HPV vaccine. So if we can get them vaccinated prior to their solid organ transplant, you're going to likely protect them even more.
And what should be done if a patient misses an HPV vaccine dose?
The good news is you just keep on rolling. So you don't need to go back. You don't need to start all over again. You just keep on going to get them that 2 doses if they started before the age of 15, or the 2nd and 3rd doses if they started 15 years or older.
And I think it's important that when you counsel about HPV vaccine, consider sometimes that the patient will not discuss the issue of costs, or they're not necessarily able to pay the series at the time that is recommended. So I always emphasize that the first dose is the most important, and you get the 2nd and the 3rd when your money can buy the dose. So some people, because they cannot afford the 3 dose, will not start the immunization. And Barbara, are there any data on vaccine efficacy in patients who have already been infected with HPV?
There is really good data to show this is not a therapeutic vaccine. So that is, if you have an active infection with one of the vaccine types, or you have a lesion like a precancer, with that, one of the vaccine types, giving them the vaccine type does not help. They're not going to clear it any faster. Doesn't boost your immune response to clear it any faster. But let's remember, there are 9 types in the nonavalent vaccine. So if you have one, the chances are you don't have the other 8. So you still get effectiveness from preventing those other type infections. And that's what I think is really important. And so, and even if you clear one, we know that the antibody response, or what you measure, doesn't seem anywhere near as strong as we see with the HPV vaccine. So you could get reinfected. Let's say you cleared 16. Great, you didn't have it for 10 years. You got a new partner, you could get 16 again. So there is some data to show that then they would be actually protected from, getting a second reinfection.
And what is the latest evidence supporting a single-dose vaccine?
So there is some really good data that's coming out of a trial that was done in Costa Rica, where the bivalent vaccine that was actually, I think, just published like a month ago, where they have 16 years of data that they are showing high antibodies, very stable, and they're also showing efficacy, that they're actually protected. Now, this trial was not meant to look at a single dose, and there is a big trial that's actually comparing 1 to 2 doses, which is very important. But we already have some data, so in the US, it's off-label. We still 2-dose or 3 doses, as I had mentioned earlier. But other countries, in fact, you'll probably talk for Canada, but in the UK, they're now doing only 1 dose. There are now 57 countries, but most of them are low-income countries because the WHO now says you can use 1 or 2 doses in both males and females aged 19 to 20 years of age. This is huge in lower-income countries because, as I mentioned, there's the cold chain, you have to have needles, you have to have someone to give it. So if we can go from giving 2 to only 1 dose, that is a huge cost saving with possibly equal effectiveness. What's happening in Canada?
In Canada, it's province by province, and even territories may have different schedules. But what is the main concern of experts in Canada is that we say it may improve coverage. We put the resource elsewhere, but no one has seen that country going from 3 to 2 or 2 to 1 dose will have specific strategies to reach those people that were not vaccinated with 2 doses. So I think the 1-dose strategy carries the same problem. How do we reach people that are not easily reached by vaccination information? You know, the biological and vaccine literacy in the population is very low. And certainly social media does not help people get the right information about who should be vaccinated. There's still a lot of false information about the dangers of HPV vaccine, but no information about the success we've seen around the world by the vaccine strategies.
No, that's really, really important. There's a lot of misinformation. And there's a lot of vaccine hesitancy, not only around the HPV vaccine, but many vaccines.
We say we need a vaccine against misinformation.
Good point.
So thank you, Barbara. Now let's talk about the role of primary care providers in education and overcoming vaccine hesitancy. I think it's important to realize that vaccine coverage is not optimal to reach eradication of HPV in the world. We're looking at elimination of HPV and cervical cancer. We know that in 2022, only 64% of countries had national HPV vaccination programs for girls and only 24% for boys. So when we look at the global vaccine coverage, WHO estimated in 2023 that coverage for the first dose in female was 27% and for the last dose 20%. And for male, much lower, 70% for the first dose and 6% for the last dose. So we have a wide range of vaccine coverage across countries ranging from 0 to 100% coverage. Affordability remains a key barrier to vaccination in many countries, but globally, HPV vaccine coverage is lower in male than female. Also, we have seen differences in perception between physician and adult consumer in Canada. And we saw that 39% of unvaccinated women stated that the reason they were not vaccinated is that their doctor had not discussed it with them. But in the same study, we saw that 83% of GPs said they routinely administer or recommend HPV vaccination to adult patients, and 55% of unvaccinated women said a recommendation from their doctor would motivate them to get an HPV vaccination. Also, GP believe costs or lack of private insurance was the major reason preventing HPV vaccination, and 95% stated it was a major or moderate barrier. But when we look at the adult population, only 20% of unvaccinated women cited cost or lack of insurance as a barrier to HPV vaccination. And 36% of GP believe dislike of needle was a major or moderate barrier to HPV vaccination, but only 5% of unvaccinated women cited dislike of needle as a barrier to HPV vaccination. We see that there's a disconnection between the perception of physician and the activity in adult. So we need much better communication strategies for HPV vaccination. So Barbara, let's discuss again some questions submitted by our audience about patient education and how to maximize HPV vaccine uptake. In your experience, what are the factors that limit vaccine uptake?
So I'm just going to say that the slide that you just went through is just fascinating, right? You put two people in the room, and the doctor says, oh, of course I gave him that information. And the woman says, or the male, I didn't hear anything about that I was really recommended that. So this disconnect is something that we need to get to the bottom because that's a problem. So that is, I think, where we begin to understand when we limit vaccine uptake, it's not just one barrier. It has multiple barriers that are influenced by social and cultural beliefs. So we know that lack of awareness about benefits, we've talked about that. I mean, if you don't know that this vaccine is a cancer prevention vaccine, then why would you get it? We also know that it's very typical, especially in my practice, like, oh, my child's not going to get HPV, not my baby. It's like, well, maybe that's great that your child's not sexually active, but they're going to get married one day, and guess what? They may have a partner who will give them HPV. So there's, again, trying to identify misinformation we've already talked about. That is so important. But it's important then for that physician to understand what is that misinformation that's going around in their community. We need to be able to understand what their hesitancy is all about. So once again, it's really important to help families, kind of go through what is limiting their vaccine uptake and try to understand it and then address that in their clinical visit. Again, in the adults, I wonder if you could even comment what you think are some of the limitations in their vaccine uptake.
Yeah, I have some parents, they ask questions about their kids, and I say, you want to be grandparent one day, but you don't want them to have sex. And we know how important it is to start as soon as possible the vaccination, even before they're sexually active. We had a good study that was done by pediatricians in Canada showing that mother overestimate the age of first intercourse of their daughter by a full year. So many parents say, my daughter will tell me when she's ready. Well, they're not doing it. And also the personal and family history. I think it's important to personalize the recommendation. So sometimes we know that the grandmother just died of cancer, and we say, well, there's something we can do to protect better your family against cancer. There's the HPV vaccine.
Well, another one that I frequently see is, oh my God, no, she's going to have a test tomorrow, and the last time she had the flu vaccine, she got a fever and she was out. So I don't want her to have the HPV vaccine. And once they're out the door, the chances of them coming back for that vaccine are very little. So it is identifying, tell me why you feel like, this is the same as the flu vaccine, or why is this different? So again, doing a deeper dive on those social and cultural beliefs.
And then what role do you see primary care provider having in improving vaccine uptake?
So I think we can kind of continue, that discussion from actually the first question, increasing knowledge and awareness. So now, we all know we don't have, 45 minutes for a patient and to talk to the parent. So, we need to be giving that information up front. We need to, recommend that HPV vaccine is a recommended vaccine. So when you give them, when they walk in the door, they get, these are today's recommended vaccine for your child, and here is information on those. You should ask your provider if you have any questions about any of these vaccines. So, you start the information kind of when they walk in, and then they can kind of move to asking you questions about what they're worried about, what they've heard about, so that you can continue that conversation in a more, what I'm going to just say, time efficient, manner. We also don't realize how powerful providers can be. Making a strong recommendation means a lot. So I think that's really the provider has to educate themselves and feel comfortable with making that recommendation. I think sending reminders about vaccinations is a really good way to promote all vaccine uptake. They get the little text message now, or they go into MyChart, and it says, these are the things that you are due. Love to hear some of your thoughts on, what do we do to get our primary care providers vaccinating?
I think the first thing would be that we learn to identify the right information that is needed to be transmitted. And we have far many more people that are ready to get a vaccine than people that are against. In the middle, we have those that are hesitant. Sometimes they want the nod from the primary care provider. Sometimes they miss an information, or they have a question, and those that hesitate, sometimes given that information, will transform them into a person that will go for vaccine or will go for their kids for the vaccine. But there are also people for all kinds of reasons that are against vaccine. And we're in a free world, and I say you can be sure that when you come back, I'm going to talk again about the vaccine, and I'm putting a note that the vaccine was offered.
So this reminds me, I often bring the adolescent into the conversation. I mean, I am an adolescent young adult, physician. So if I hear even hesitancy or the discussion, the adolescent has a mind. They can actually, say, wow, yeah, I would really like this. And I've seen it where, I'm offering it to an adolescent boy. And, I talk about penile cancer, anal cancer, oral pharyngeal cancer, protecting other women. And mom is like, I don't know. And then, she looks at, the kid, and the kid says, yeah, I'd like to have that vaccine. And the mother's eyes get really big, like, I know you're not telling me something. but the adolescent has the right to become part of that conversation. So I really also want to recommend that primary care providers do involve the adolescent in that conversation.
Yes, so let's go to the question 3 and your experience. What do patients and or their parents, caregivers wants to know about HPV vaccination?
So first and foremost is the safety profile. Is this safe? Because we have heard about the HPV vaccine now for many, many years, a couple decades. Many parents have not. So we know it has a high safety profile. They do not. We need to communicate that. And then I think we need to put across, what is the purpose? Why are you giving me this vaccination? And you can talk about, it's the first cancer vaccine that we really have on the market. And so, the patient says, well, they're not having sex. And I'm saying, that is great, because they're really going to get protection. So what you want to do is saying, wonderful news, your kid's not sexually active. Let's do the vaccine. So I think, again, it's really kind of that information, safety profile, and the purpose.
Yeah, I think it's good that we talk about also the fact that it's more and more unpredictable. What will be your sexual life when you're starting your sexual life, or even many years after your sexual life? Look at the number of patients that are divorced, what the spouse that deceased, for all the reasons that would exist. People will become newly active with partners and at higher risk. People go for STD screening and HIV screening, but they don't think about having HPV vaccination. So That's it, Barbara. Thank you for your information. I think that we had a good overview of the need to improve information and counseling about HPV prophylactic vaccine. Thank you for your attention. See you soon.
Always a pleasure to talk with you, Marc.